All right, so we'll go ahead and begin our presentation on managing chronic pain. And here is your instructor, Becca Smiley. Oh, and you're on mute, Becca.
Classic. Thank you for the introduction and thank you for everyone that's here. Can I have somebody that can confirm that they can see my screen?
Yes, I see the PowerPoint.
Okay, excellent. Okay. Awesome. So yeah, thanks for the great introduction. And this talk is scheduled for 2 hours, but that's because the last time we did it, there were just a lot of questions. And so we'll leave plenty of time for questions. We'll leave time for breaks. And so the content will take up a good amount of time, but the content itself won't take up the full 2 hours. So let's just talk about what we're going to talk about a little bit today. Okay, so first we're going to talk about what the goals are for today. We're going to define pain. We're going to talk about how providers can manage pain. And we're also going to talk about understanding pain. I want to also share that a lot of what I'm going to talk about today is from the perspective of a provider, because that's what I am as a nurse practitioner. So a lot of this is kind of talking about chronic pain and what you should expect from your provider in terms of, how your provider is going to manage something like chronic pain and, expectations for quality care. So I, looked up a lot of stuff through National Institute of Health about chronic pain. That's where a lot of this content is coming from, and also the CDC. And NIH says that over 1/4 of the United States citizens suffer from chronic pain in some capacity or another. And also, I think the most important thing is really like how patients' chronic pain gets managed can have a profound impact on their quality of life. So it's really important for primary care providers or providers in general to have a good sense of how to manage chronic pain. And what that means is combination therapies. It doesn't mean picking one medication, sticking to it, and if it doesn't work, then, that's it. Or even picking one alternative therapy. I mean, it really has to be a cascade of many, many things, and it needs to be one thing at a time. So we're going to talk about that. So that combination therapy and kind of a stepwise approach. We're also going to talk about how to escalate and which medications are most appropriate for which kinds of pain. And we're also going to talk about really like the physiology of pain, like what causes pain. We're going to talk about the mental stress that pain causes. And, there's a lot of statistics and numbers out there through NIH and CDC mentioning that depression and anxiety are widespread for those that are suffering from chronic pain. So important not to leave out the mental load that people are carrying when they're suffering from chronic pain day to day. So these are all things that are important for your provider to consider when looking at somebody's pain. All right. So next, let's focus on this slide, just specifically on the picture here. This is just talking a little bit about like what pain, like what it really is happening with pain. And, there are this nervous system that connects these little tiny nerves in like, say your hand, if you touch a hot stove. You've got afferent and efferent nerves. Afferent nerves are going up into the brain and they're carrying pain signals all the way, up through these peripheral nerves into your spinal cord, and then it goes up into your brain. That is processed in your brain, and then it goes back down the efferent pathway through the spinal cord, through the peripheral nerves. So I think the reason I wanted to add this picture is because, so much of it is actually processed in the brain. And so pain messages can get modified over time, especially if there's like a recurring sense of this same pain over and over again. Messages can get more wound up in the brain if it's over and over and over again. So that's why sometimes chronic pain can even become a disease of itself versus like a symptom of something. So that processing in the brain is where a lot of this comes from. And so I think with all of that said, pain is most important to say here is that pain is an experience. So you feel pain emotionally, you feel pain physically. It's important to say that it's not just a physical experience, it can be an emotional experience too. And so, there's no thermometer or blood test to say how much pain somebody is in. So it's truly a subjective experience. It's an experience and it's a subjective experience, and you have to really take the person's perception for what the pain is that they're experiencing at their word, because again, there's no test for it. So, there are things that you use, especially like in the hospital setting, and I'll use a lot of references to being in the hospital because I work inpatient in the hospital. So, there are charts to look at, if somebody is sort of giving you signals of pain that are not just them verbalizing it, but you do have to take someone's verbal expression of pain at their word. That's really important for providers to understand. So, and then, okay, so then I wanted to also just mention that, pain typically is associated with like tissue damage or something that's occurring, but again, it can become its own disease itself, chronic pain can. So it's important to know, if there is an underlying cause, to get to the bottom of that, because I think the biggest thing is if you are not getting to the bottom of it, it can actually be really distressing to the person that's experiencing the pain to have no answer for really what's causing it. And then that distress and then that mental load, that gets even heavier. So we're going to talk a little bit about chronic pain versus acute pain. And acute pain, there are two different, it depends on if you look these up through like NIH or National Institute of Health versus other resources, but mostly it's between 3 and 6 months. Acute pain lasts usually less than, I'm going to say 6 months, but some references will tell you 3. And acute pain is a useful sign that something is wrong. And that often rest is recommended if you're experiencing something acute and new. And acute pain is expected to go away. On the other hand, there's chronic pain, and that is when it lasts longer. Again, it's either 3 or 6 months. I'm going to say 6 months in this case. And that is when pain can become an illness itself. And it's no longer just simply saying that something is happening acutely, but it's this processing that's happening in the brain over and over again. And that doesn't mean there isn't damage happening to the tissue, like say arthritis. That's one of the most common, musculoskeletal chronic pain issues that people experience. And that's not to say that that damage is not, occurring or even getting worse over time, but that the processing actually can make it so that it can make it worse too. And the bottom line is, they say if it's chronic pain, it's no longer a useful warning sign. If it's been there for greater than 6 months, it's not telling us that something new is happening, something different is happening, unless of course the pain changes. And then also resting too much can make things worse with chronic pain. And we're going to talk a little bit about that, but the bottom line is what providers will say is, a lot of these sort of supportive ligaments and muscles that are there, and I'm talking a lot about more musculoskeletal pain at this point, but any sort of pain that makes it so that you're sitting down all the time, you're going to have a deterioration of some of the strong muscles that support things like the spine. And then you might end up with, back pain as a result, because you're not moving as much, even if your chronic pain had nothing to do with your back. Maybe it had something to do with your knee or whatever. So the point is resting too much when you have chronic pain can actually cause a cascade of events. So next, I want to talk a little bit about physical pain versus, going beyond physical pain. That is the psychosocial model of pain. And what people are experiencing when they have pain for longer than 6 months and sometimes years. The first thing on this little screen here is you see this person at the very top, like at 12 o'clock, and this person's experiencing a persistent level of pain. And then you move on to this person becoming less active because their shoulder hurts. It looks like this person's shoulder hurts. And because of that, they are not moving around as much. They're giving themselves rest. But if you take that rest and you take it on to years, years and years and years of resting more, then you're losing a lot of your fitness and your muscle strength and all of these joints and things that are supporting important structures in your body. Then you have a loss of those things, and that can actually lose the support of those important structures and cause more pain. So we often then will turns into having less energy if somebody's not moving around as much. And then they have new and different chronic pain symptoms. And as a result, there's usually some level of stress or anxiety or fear, often frustration, that is associated with this. And these negative thoughts often accompany negative moods. And then, people are commonly wondering about the future for themselves and about what the pain is going to look like in the future and how it's going to affect their job or, their life in general. Things change if they feel like they can't do the things that they used to be able to do. And that's why it's important for providers to kind of have these conversations about, even alternative exercises. And then we'll also talk about a little bit about like timed interval sort of like activity. There's data out there that shows, if somebody's suffering from chronic pain, then there are ways to kind of get them out of this cycle. And the negative thoughts, the negative fears then turn into, can turn into depression. It can turn into mood swings. It can turn into needing to take more time off work, becoming worried about money. And that's how you can see how chronic pain affects every area of your life, including your physical being, your emotional being, how you interact with others. And another important statistic that I wanted to mention here was that National Institute of Health shows that people that are suffering from chronic pain will have at some point in their life up to 20% of those suffering from chronic pain at some point in their life. And this is not a chronic thing, but just at least once will have suicidal ideation. And I'm not talking about suicidal intent, but I'm just talking about depression to the point where they're thinking about the ideation of something like suicide. So this is not to make it too serious, but I think the point here is that the mental stress and this depression and these things that are proven to be associated with chronic pain have real consequences. And it has real consequences when it's not managed appropriately. So we're going to talk a little bit about the different types of pain, different medications that are best for each type of pain. So I wanted to stop here though for a minute and see if there are any questions in the chat or anything that I should be, because I'm not manning the chat.
Yes, we do have a question here. Sometimes clients and patients want to get a wheelchair when maybe they don't need it. How do you have that conversation?
Okay, and I'm assuming that clients and patients maybe want a wheelchair because of chronic pain, I'm assuming. Yeah, that is, and I'm assuming also it's like maybe to an appointment or maybe it means just in general, and I'm not entirely sure. But I will say this, that we're going to talk a little bit about this sort of encouraging people to stay active through their chronic pain and what that looks like, what the encouragement looks like. Not only that encouragement, but also like giving them tools, because just simply telling somebody, oh, you really got to get up, this is really bad for you, is not necessarily going to be the most motivating way to do it. But encouraging somebody with small steps, like, oh, well, you have to be, the goal is to be active for at least 10 minutes at a time. So I think the question I would have maybe is like, get to the bottom of like maybe where the need for like a wheelchair comes from. Is it out of fear? Because that would be my suspicion, is that it would be out of fear. So I would ask maybe why it is that this person maybe might want a wheelchair. And it's probably out of fear of something, some flare up of pain or something like that. And then I would say that, like, encourage them to know that, okay, so if you do get to the bottom of it and say it is fear of pain, then, come up with a plan for like when to do rests, when to sit down, when to, push yourself, how long to push yourself. Okay, we're only going to walk for 10 minutes and then we'll make sure that we find a place to sit down, that type of thing. I think that's all me thinking about the perspective of somebody wanting a wheelchair, like go to a doctor's appointment or something, or maybe it means they just want a wheelchair in their house all the time. And I think the same applies though, which is get to the bottom of exactly why they're asking and then help come up with an alternative. Because I agree, sitting in a wheelchair when you don't really need it is going to cause more of that back to the pathway of, resting too much and causing a cascade of, worsening events. So thank you for that question.
Thank you, Rebecca.
Okay, so the next thing I want to talk about is somatic pain, visceral pain, and neuropathic pain. And this is where we'll like talk a little bit more about medications. I'm going to talk a lot about medications here that are not necessarily opioids, because I'm going to get to opioids in a little bit. There's like a few slides that are just dedicated to that. So if you're wondering when I'm talking why we're not talking about that, it's because we'll get to it. But I will say that, there's different, for somatic pain, visceral pain, and neuropathic pain, there are different medications that work best for each one of these. And somatic nerves are connected mostly to skeletal muscles and musculoskeletal sort of like innervations of like where the nerves come into the muscles and then connect to tendons and then connect to bones and stuff. So visceral pain is more like in soft tissue of like our organs and stuff like that. So commonly, one of the things that we'll do when we're trying to decipher whether or not somebody's suffering from somatic pain versus visceral pain, and you'll see why it's important to know, because the difference changes a lot of, the ways, like the way that we can treat it most effectively. We will generally say that, somatic pain is more like of an aching and like a throbbing, and visceral pain is more of something like somatic pain is more like aching and throbbing that you can kind of like point to, but a visceral pain is more like a dull sort of experience commonly, and that is something that you often can't point to a very specific location. So after surgery, when, we have patients that have big complicated surgeries and they say, I have pain in my abdomen. One of the things that we'll do to differentiate the type of pain, and partly so we can find out exactly what's going on, is we say, can you point to it? And if somebody can point directly to one spot in their belly, then more likely it's not going to be that sort of like the pain that's associated with like soft tissue organs. Generally, that's more like diffuse. And neuropathic pain is also, it's separated into central nervous system and like peripheral nervous system. And it has to do with damaged nerves firing ectopically, like unnecessarily. So we'll talk about that too. But somatic pain, let's just first start with that. Usually it's caused by like trauma of some sort, like a cut on the skin, or a fall, or like strained muscle use. Also, they say that a bone fracture is more commonly associated with the somatic pain. That's again because it's like the more musculoskeletal nerves, and diseases that affect the muscle or the bones, like osteoporosis or cancers of the bone. Those things can be a lot more somatic in nature. So somatic pain also a lot of times is like arthritic pain. And I think I'm just going to talk a lot about arthritis throughout all of this, because so commonly a lot of these chronic pain experiences that people have to do with arthritis. There's also pain related to like cancer and other diseases that are really serious, that are, you know, have a special sort of like class of way people look at those pains. And we'll talk a little bit about that, but arthritis is one thing that I feel like that I'm going to probably make reference to a bunch. So this is all to say that arthritis, that one specifically is a swelling often of like your joints. And if really the best thing for this somatic arthritic pain is NSAIDs. And NSAIDs are like ibuprofen. That's the class of medication. It's like ibuprofen, Advil, and like Aleve. All of those medications are the same. And also Tylenol is a really helpful one. This little table that is in this slide also says opioids are an option, but I think I want to focus mostly on Tylenol and NSAIDs, because these things really actually stop some of the events that are causing some of the pain. Opioids block one receptor. It's the mu receptor that processes pain, but actually Tylenol and ibuprofen, in that class of medications, can stop the cytokines are these proteins that draw white blood cells and like lymphocytes, neutrophils, all of these really important, cells that are associated with swelling and inflammation, and those things are associated with pain. They also they cause vasodilation, they cause fluid to come to this area. All of these things are like when you have somebody with arthritis and they've got a hot, swollen joint, it's because of this cytokine release that's what's causing this. And so if you take ibuprofen, if you take Tylenol, it stops some of that cytokine release, and it stops some of the drawing of the fluid. It stops some of the vasodilation that occurs. So it's actually doing something more direct to the pain versus just blocking it altogether. So that was a big important piece of, all of this that I wanted to focus on, because I really like using Tylenol and ibuprofen if people can take it. And commonly, because I work in urology, oncology, and we deal with cancer type pains, but we also we do surgery on people in the hospital, and Tylenol and ibuprofen after somebody has had surgery are really effective. And oftentimes, we actually did a study at Stanford that looked at using no opioids at all for patients that have their prostates taken out, a radical prostatectomy. So that's incisions into the abdomen to take out, an entire organ. And I was a part of a group that compared removing opioids from the whole process, and patients were doing fine without them. People left the hospital and never called and needed any opioids. I mean, they had the option, of course, but people did fine without it. And it's really optimizing those medications where you can, and you can make a big difference. And it reduces a lot of the side effects that opioids cause. That's all with the caveat to say that somebody can take Tylenol and ibuprofen, and I'll talk a little bit about that too. because, not everyone can take those medications. So next is visceral pain. And this is more like related to things like visceral pain. Examples are acid indigestion, like acid reflux or GERD, digestive issues like chronic constipation, or damage to specific organs. I think like pancreas and liver damage can cause more visceral pain, and also it looks like there's like a lot of more, if there's like a cancer involved, and then this is more of like the visceral pain is more commonly what's experienced if there's like a solid organ, sort of, like a liver or pancreas or stomach or something like that that's involved in some of that disease. Then people aren't necessarily experiencing somatic pain. It's more commonly a visceral pain, and it's more like the generalized thing that I was kind of describing. So research shows that actually NSAIDs or like ibuprofen, Aleve, those things are helpful. Tylenol is helpful, but they're not as helpful as the somatic pain. So this pain is better managed with opioids, actually. And this pain is also, sometimes steroids are an option for this type of pain. And this is not to say that steroids aren't an option for the somatic pain too, especially like for arthritis, because I'm sure that you've all heard of people getting injections into their arthritic sort of knees or joints or whatever, and those things that can really help. And actually steroids, they help that with the whole inflammation or like cytokine cascade that I was describing earlier with all the swelling and in arthritic joints and stuff. So it works in a similar way, just differently, but it, like, the result is like it stops all of that swelling and stuff. But steroids, particularly for more visceral type pain, is something that they'll do sometimes. The big caveat with steroids, though, is if it's not being injected into a certain spot, specifically like a joint, steroids are they're medications that come with a lot of side effects, and it's not something you can really take for a long period of time either. You can, but it's not without a lot of side effects. So that's just to say that they're options. Steroids and opioids are good options for that type of pain, but it just comes with more side effects. All right, next we're going to talk about neuropathic pain. And so this one I left a little bit for, like, I separated it a little bit because it just works so differently. And the idea is, like I said, like I said, it has to do more with, the nervous system and nerves firing ectopically. So things that I wanted to talk about is like the experience of like burning and the experience of numbness and tingling. Then those are things that are more commonly associated with neuropathic pain. And neuropathic pain is, due to that ectopic firing, damage to nerves, and again, it causes those symptoms, and it can be a result of diabetic neuropathy. Neuropathy is the big one. Neuropathy is like an umbrella term for these damaged nerves. So it can be alcoholic neuropathy, diabetic neuropathy, cancer-related neuropathy, because chemotherapy damages those nerves, especially the very small ones, like at the fingers and stuff. It damages them a lot. And so that's why people that are getting chemotherapy end up with like numbness, tingling, and even like this like burning pain at their fingers. Also phantom limb pain, like if somebody has I'm sorry, I can't think of it. If somebody has to have an amputation for some reason, that's the word I'm looking for, then it's a really weird experience, but people can have pain in, like, if they have a foot removed because of for whatever reason, if something like that happens, then the experience of pain there can be really, really intense, and it can be like that burning and the tingling in a foot that's not even there. And it's because the body is firing off all of these, all these nerves and trying to communicate with the foot that's not there anymore. Also, shingles pain from, older people can get shingles. And this is, I think Dianne Feinstein has been like out of, she hasn't been able to be at work for, I don't know if you guys have like followed this, but for like a while, and it's because she has shingles. And like, this is, I think I bring this up because I think there's like this narrative that like, why is she out of work so long? And this is like more of like a political thing that I've like been listening to, but the pain side of my brain is thinking, no, this is a really, really painful experience, and people can be out of commission for a long time because of how intense this neuropathic pain is related to shingles. And it can also actually cause like some chronic damage to those nerves, and then people have to live with some amount of like chronic pain. They call that like, there's a word for that type of neuralgia, or like post shingles neuralgia that people experience. So it can be serious. And then also people that are experiencing central nervous system disorders like stroke, or a recent stroke, or Parkinson's, or multiple sclerosis. Those are all things that can end up with those types of neuropathic pain. So what do we do about neuropathic pain? Because this is a whole different type of pain that is not even touched by any sort of Tylenol, ibuprofen, steroids, opioids, none of it. It is all things that can suppress like the central and peripheral nervous system, and stop some of that ectopic firing that's occurring. And those medications are things like gabapentin, if you've heard of it, or Lyrica. But this comes with side effects too, because it causes, most commonly, Lyrica and gabapentin. Those are the two big ones that you'll see. Other ones are tricyclic antidepressants. And that's like a whole class of antidepressant medications that can get added to the Lyrica and the gabapentin. But usually at the baseline, if somebody has neuropathic pain, they are on gabapentin or Lyrica, and then things are added like the tricyclic antidepressant. And then on top of that, sometimes people will add, they'll try opioids or something like that. The research for neuropathic pain and things that can help with it is, there's a lot out there, and there's very little that says like opioids help that much, but commonly people will try, and sometimes it helps for people. So that's kind of going back to the stepwise sort of process in which pain is managed. The Lyrica usually starts with gabapentin. Then if that doesn't work, then you switch to Lyrica. And then you add on something like a tricyclic antidepressant. And the important thing to know about these drugs is that it causes sedation. It causes people to feel really, really tired. It causes confusion. And especially for older people. So if like somebody is 65 or older, you really have to be careful about how much you give of these medications. And that goes for opioids as well, because actually for similar reasons, it causes confusion, it causes sedation, and especially again for older people. Let me just make sure that I have, oh yeah, okay. So this slide, I wanted to talk a little bit about Tylenol, gabapentin, ibuprofen, and like the medications and when to use them, when to not. We just talked about pain and which medication, different types of pain, what's causing it, different types of medications that are best for it. But the other thing to really understand too is like that not all medications are safe for everybody. So like I said, ibuprofen, this is a big one in this whole class of medications. So ibuprofen, Aleve, all of it. It is not safe for people that have chronic kidney disease because it's all processed through the kidneys. It's not safe for people that have a history of a stomach ulcer. And that is because it can cause if you're taking a leave every single day, then you've had a history of a stomach ulcer, like a GI bleed, it can increase that risk of that coming back. And what doctors will often say is, even if you've never had a history of like bleeding, an ulcer, or anything like that, always a doctor will tell you, or a provider, I should say, will tell you to make sure that you're taking Aleve, ibuprofen, any of those, with a full glass of water, and even sometimes like with a cracker or something, because doing that on an empty stomach increases your risk of having that complication. And then there's also data to suggest that it's not safe for people that have had history of a heart attack or like heart disease, and that is that's because it can increase the risk of that happening again. So people that have, again, GI bleeds in the past, kidney disease or heart disease, taking ibuprofen, taking it once, that's fine. Like if you have a headache or something and you've had one of these issues and you're drinking it with a full glass of water, it's probably fine. But I'm talking about people that are asked to take this every single day for chronic pain. It's not safe for those folks. That also goes for people with kidney disease, for the gabapentin. And gabapentin can be dosed to a point that's safe for people with certain amounts of kidney disease, because kidney disease is on a stepwise level. And so it's not completely not an option for those folks, but you can reduce the amount that you're giving, and it's all processed through the kidneys as well. But it's also something to understand that gabapentin and Lyrica are not always the best options for those folks as well. And then we'll also talk more about opioids again in a little bit, but then also I wanted to mention that Tylenol, again, I would say Tylenol of all of these medications is probably one of the safest things that you can take generally every single day, with the big exception of liver disease. So if you're somebody that has liver disease, or you are like, even if you're somebody that has several drinks a day, you really shouldn't be combining alcohol and Tylenol, and you shouldn't take Tylenol at all if you're somebody with liver disease, because Tylenol is completely processed in the liver, and so is alcohol. So you can't overstress those systems. And then we're also going to talk about physical therapy and other options for like that stepwise treatment. But I want to take a moment here to see if there are any questions in the chat.
Yeah, I think there are quite a few questions. I don't know if this is a good time to address those.
Sure.
Yeah, okay. So let's see. Let me take a stab at it, Christine. So the first one has to do with basically just definitions. Ectopic firing, for some people who may not be familiar with that medical process, if you can just clearly explain what that means, so that in reference to what you've said, that can be better understood.
Sorry. Okay. It's like spontaneous firing of nerves that are generated like not at the normal time that like the brain is telling those nerves to fire.
Okay.
So they're like overstimulated nerves that are overfiring.
Outside of normal nerve firing. Okay. The second question has to do with, as a social worker, and this is from Cassandra, thank you. Social worker in aging, I'm constantly being told stories by older adults whose pain had been managed by opioids for decades, but now with the opioid crisis, many of them are being taken off them. The universal complaint is that the alternatives like NSAID, like you were saying, gabapentin, Lidocaine patchlets, etc., do not work as well, and they don't understand why the better pain meds are being taken away. And she's tried to explain the crisis to her clients. Many are very upset, trying to switch doctors as a result. So wondering if you had any advice about how to talk to clients about this, and if other service providers are experiencing the same.
Yeah, that's really tough, because I do sympathize with these people where if they've been on the same medication for years and years and their life is being affected by switching to other medications, I I don't necessarily, let me put it this way. I do think that reducing the amount of opioids that people are taking is important. I also think it's important to reduce the amount of opioids that are just out there because of the opioid crisis, because of the overprescription of opioids and everything that has occurred in the last, like 30 years or so. But I will say that I think one way that I would talk about it with somebody first is I would probably ask them, you know, how they feel like it's affecting their life exactly, and try to find out to the extent in which it's affecting their quality of life. Because if it is such that they feel as though their quality of life and what they can do is being dramatically decreased because they are being switched off of this medication they've been on for years and years and years, then uh, you know I do think that that's worth more of a conversation with their provider, because I don't necessarily agree with just taking people off something they've been on for a long time. Reducing it, if it's possible, should absolutely be tried. So I think one way I would approach it is trying to see kind of how open they are to any sort of changes, because I think one thing too is that patients get really, when they find that something's worked, uh, I don't blame them for wanting to keep it. But at the same time, if there's an option to reduce, even if it wasn't opioids, even if it was something else, if there's an option to potentially see how they do without it, then I think that's something that everybody should be encouraged to consider.
Yeah.
So, my answer to that question, I think in general, would be find out exactly how much it's affecting them and see how open they are to the change. Because if it's as simple as somebody suggested it and they, haven't the client hasn't even tried not taking it yet, then it might just be that they're nervous and they're scared about the option of it. But also, it's like a lack of control thing too. And maybe it's not even actually their pain is not, something that can't be managed with the other options. Maybe it is something else that's going on.
Yeah.
So I think my answer to that is just sort of like be inquisitive, ask sort of like what's the biggest problem, and if it really is like their quality of life is worse with the change in medication, then I mean, I guess I would encourage a conversation with the provider about it.
Right. I think that's wonderful. And that's really the general approach that we would like for all the providers to take, Becca. I think in addition, the inquisitiveness, as you're saying, also offering a comprehensive type of alternative types of managing pain so that they begin to see that they do have more choices. You had mentioned physical therapy. There's also a lot of mindfulness exercises people can do, movement, music, not so much alternative, but comprehensive, so that in addition to what Becca's been talking about, also for our patients or clients to consider that there are other ways, so they're not just locked into taking a pill. Yeah.
And along those lines of alternative treatments, there has been a couple of questions. Do you have any experience with the effectiveness of acupressure for self-care?
Yeah.
What was do you say acupuncture?
Acupressure.
Acupressure.
Acupuncture.
Got it. Okay. So I was going to talk about acupuncture in a little bit, but acupressure is a separate thing. And I know that there are a lot of, and I'm not going to talk about that in the rest of this, so I'll address that first. The acupressure, like the points of massage and like it's mostly, I think it's like mostly chiropractors that do this. And this is, you know, they can treat things like nausea, they can treat things like chronic pain just by pushing in certain points of your body. And I know that there's research to support some of this. So I think I wrote a little bit about what physical therapists do. And physical therapists also provide this sort of acupressure and this massage therapy. And the massage therapy is not just, you know, getting a massage. The massage therapy is, you know, this it's specific to some of these things, and specifically like the acupressure. You can do, so I know physical therapists offer it, and I know that chiropractors offer it. I'm not talking a lot about chiropractors in this talk, but I am talking about physical therapists that that also offer similar things. And so you can see it's actually on this slide that we'll talk about it. But acupressure, I know there is evidence to support, you know, its use. There's not specific sort of studies that I can point to, but I know that it's used by physical therapy a lot, which is good.
Great, thank you. A couple more questions related to medications. What type of pain are migraines, and then what medications are best to use for this type of pain?
Yeah, that's a great question. So migraines are, I'm pretty sure it depends on the type of migraine, but I know there's vasodilation involved in migraines, and generally that would be more of a somatic pain if there's like the vasodilation and the swelling. I'm pretty sure that vasodilation is the cause of migraines, like in your brain. So there are options for I would say the best thing just over the counter would be like an ibuprofen. But I know there's a lot of other things out there, because there's also different reasons for getting migraines. It depends on the type of migraine and the type of sort of headache that there is. And there could be a whole talk on headaches and migraines actually, because there are different reasons for each one, and sort of like if you can, you know, if you're saying that like that it's a true migraine versus like pressure in the front of the skull versus, you know, there's different kinds of migraines and headaches and different causes. But I would say generally of the medications I talked about, ibuprofen is the best one for that. And then, you know, there's also caffeine causes some amount of like constriction that can help. And so that's why people will take Excedrin, is like a mix of caffeine, aspirin, and I have to look it up. I think maybe, I can't remember, but there like Excedrin is like a combination medication that can reduce some of that swelling and like some of the cause of that. But it kind of depends on the type of migraine and the type of headache to say which medication is best.
Okay, thank you, Becca. Just three more quick questions. I think one is just to clarify for definitions for people who are in the more psychiatric mental health field. Psychosomatic is kind of more often has a negative connotation. So can you clarify further what somatic pain is by simple definition from a medical perspective?
Okay, well, I didn't say psychosomatic.
No, I know that, but I think that there was a question about people in the mental health field. This is from Cherie. That's the term somatic is often associated with, you know, it has kind of a, like you're making it up kind of.
Okay, well, yeah, that's, if you say psychosomatic, that's a completely different thing than somatic. And somatic has to do with where the like actual nerves are connecting into somatic tissues. So there's like a physiological reason for using the term somatic, and it has to do with the somatic nerves and
the physiological etiology. Okay, thank you. And then two other questions follow up to type of medications for certain situations. Can you speak to regenerative medicine treatment And then what would be a suggestion for non-sedating pain management medication?
Okay, so non-sedative medications are the ibuprofen and the Tylenol. Of the things that I've talked about, really, I mean, there's like lidocaine patches that you can get over the counter that don't have any sort of sedating effects. And then also I can't remember what it's called, like if you just buy it over the counter, but there's like patches, I might have it later in these slides, I'm not sure, but patches that have like ibuprofen in the patch and it just goes straight to the joint. So any sort of patch usually that you can get over the counter like that won't have any sedating side effects. One big caveat with patches is like if you have an open injury, like a cut or something, you can't put a patch right on that because that's going to like get over absorbed. And not that it's going to cause more, it's not going to cause like sedating effects, but you can't, lidocaine actually can cause sedating effects. I mean, I don't think if you put it over a cut, it's going to cause that, but I'm just saying in general, you have to be careful with putting patches on things. Usually it's like for lower back pain or like arthritic pain and stuff. And regenerative medicine, you know, I'm sorry, I'm going to just say that I'm not entirely up to date on the latest sort of like what regenerative medicine is doing. And I know that there is a lot of like, I'm pretty sure when there's options for people to get these like regenerative medicine, these regenerative injections, like after they get like a bone injury to like promote healing and stuff like that. I know that there's stuff coming in terms of like more studies to make it, because I don't think it's covered by insurance right now for a lot of these things, for a lot of these injections and things I'm thinking of. And I think I'm thinking of the right thing that this person's referring to. So if you do it, I think you have to like pay out of pocket for it, because a lot of insurance companies won't pay for it because it's not completely proven that it works yet. But there's a lot of encouraging studies out there that's showing that there's more to come. So I don't have much to say about it right now, but I'm hopeful that it's going to be a really important class of medications, especially for things like, you know, fractures and, you know, injuries like that.
Great, thank you so much. And then just not so much questions as comments from our participants. Nikki mentions that acupressure is common at home, self-administered, not just by our chiropractors. And acupressure, as we know, has been based on a lot of old Chinese, Japanese pressure points, which really correlate with a lot of the neurologic physiology that we now understand from Western medicine point of view. Patty mentions that physical therapy also offers trigger point dry needling for pain management, as specific techniques as myofascial release, both of which require advanced training and certification. And aspirin cream, topical cream is good. So those are the comments.
Nice. I didn't know that about physical therapists offering that. So that's great. Thanks for that comment.
Okay, great. And a comment from Megan, soma means body. Okay, and question, can a person have both somatic and visceral pain simultaneously?
Oh, yeah, definitely. I think it depends on exactly what's going on. I think to a point, there's probably, it depends, you know, exactly like where the damage is and in what way the damage is occurring. But somebody can have all of these pains at the same time, for sure.
Two more additional. One is, what are your thoughts or clinical experience with CBD and or turmeric for inflammation and pain? And we will touch on that. I know. And then from Amy, it's thank you so much for these information. Apologies if you addressed it and I missed it. Question is, what is complementary therapy? Thank you.
What is complementary therapy?
Mm-hmm.
I think and tell me if I'm answering this
Yeah,
wrong,
yeah.
but complementary therapy to me means like it's it is ways to complement and add on to the therapy that's working for somebody, or doing like that you don't want to take away. It has to, it can't be the sole or only therapy, because it's not enough. But complementary therapies can get somebody to the point where, you know, say they're taking Tylenol every day for their arthritic pain, and then the complementary therapy of like physical therapy or acupuncture, acupressure is also helpful. Then those are the complementary therapies.
Yeah. On point. I mean, basically, it's the yeah, that's exactly what it is. It's the approach of managing pain from one thing complementing another. So it's a belief that, you know, medication and physical therapy, mindfulness and rest, exercise and good diet, you know, so it's basically one thing very seemingly diametrically opposed to the other, complementing each other so that you actually have a more comprehensive, hopefully positive outcome for managing pain.
Yeah, definitely. And then I am going to talk a little bit about like CBD and that kind of stuff. So I'll talk about that in a minute. But yeah, so okay, thank you for those questions. I think I want to say that the questions and the comments really add a lot, because I don't know everything. You know, I think there's a lot of people out there that have experienced things themselves that I haven't experienced, or they're working with clients in the community that are experiencing things that you know, like I don't see it in the hospital, or I don't have a lot of experience with. So even if it's not a specific question, like those added kind of comments can add a lot, because I didn't know that about physical therapy. So thank you for that. And yeah, keep it coming. It's awesome. Okay, so next I just wanted to talk a little bit about those complementary therapies, or like other options, and other things other than just medications, because I ended it there with medications. But next there's physical therapy, and also chiropractors, and then also, yeah, like somebody said, you can do these things at home. If you've got somebody that knows how to teach you to do some of these, you know, physical therapy will give you a lot of exercise. Like you can go to a physical therapy appointment 2 times and get all the exercises you need or something. I mean, you know, hopefully you, maybe if you feel like you need it, you go more than that. But sometimes it's just like a getting to know exactly what you need and getting some options for doing stuff at home. So yeah, doing stuff at home and exercises at home, pressure at home, those are all really good options. So some types of pain respond really well to physical therapy, and sometimes it's about you know, building your strength. Sometimes it's about that, you know, massage therapy or acupressure. Sometimes it's about stretching certain muscles. Physical therapists, I just have the most respect for. I think that they are experts in their field. Physical therapists can manage so much, and chronic pain is, you know, just one of them. The other thing is medical procedures. Like, you know, sometimes people will have this like these really horrible conditions, like I'm trying to think of, I can't remember what it's called, this nerve issue in your jaw that causes a lot of pain in your jaw. And sometimes they'll do something as extreme as like go to the nerve that's causing that, and, you know, like clip that nerve and like kill it. And that's like a very, very extreme example, and people wait a very long time before they do something like that. But these like nerve blocks and, you know, surgeries and like snipping these overactive nerves, all things are, you know, medical procedures are options for, you know, some of these certain types of medications. Even like a knee replacement surgery for somebody that's been on, you know, pain medication for a super long time, and it's time for them to just get the knee replacement surgery if they're healthy enough to. That's even a medical procedure that can help with chronic pain. There's also things like electrical currents and ultrasound, and there are other sort of things that there's some clinical evidence to support the use of these, and like nerve stimulators and things like that. So these are all medical procedures and things that have been proven to help with certain types of pain. A lot of it is like nerve related pain, and those complementary or supplemental therapies also include, importantly, it's like heat and cold therapy. That's not something to be overlooked, and like putting a hot pack or a cool pack on something that's causing you a lot of pain, not to overlook it, just like you shouldn't overlook like Tylenol and ibuprofen as options. And then also like things like meditation, biofeedback, and like relaxation. That's where some of these other things like yoga can be really helpful, really helpful for sort of like the stretching that we see, and the stretching that physical therapy helps you do, and like strength building, but then it also adds in the added like meditation piece. So those are also really nice options. And then also I wanted to comment on acupuncture, because it's something that's been around for so long, and Western medicine didn't start adopting it until until much later. And Western medicine still, like if you look up exactly what Western medicine's theory of like how acupuncture works in the nerves, it's still sort of unclear, but the evidence is there. The evidence is there to say that it is in fact it's a useful way to manage chronic pain. So most insurance companies will cover acupuncture therapy for chronic pain, and that's because there's so much evidence to support its use. So that is something I wanted to also mention. And also acupuncture, according to the National Institute of Health, also says that acupuncture can help with things like seasonal allergies and stuff like that. So it's not just for pain, it's for other things too. And then lifestyle changes. This is the last one that I didn't also want to be overlooked, because like good nutrition, staying hydrated, staying healthy, all of this stuff really makes a difference. Maintaining a healthy weight, all of that makes a big difference in people that are suffering from chronic pain. So, reducing the amount of stress that you're experiencing, and all of this is, if you can, obviously, if it's an option, then it should be encouraged by providers. Okay. Next, we're going to talk about like marijuana and CBD. But I just wanted to mention that there are, I try to really only use like certain resources for talks like these, because there's a lot of stuff out there, and I could cite all kinds of individual papers and all kinds of things to give you evidence for any of sort of for a lot of this stuff, especially something like use of like CBD and marijuana, because there's so much out there. But I wanted to really stick to like National Institute of Health and CDC. So the Centers for Disease Control agrees that marijuana is a useful tool for helping neuropathic pain. And also there's a good use for CBD and marijuana in increasing appetite and helping with nausea. But since this talk is about pain, I won't talk too much about those. But I think the thing I wanted to comment on is like the compiled research and the compiled data is that neuropathic pain is the thing that people get most benefit out of using these these supplements from. And the National Institute of Health also says that it's neuropathic pain. And the National Institute of Health looked at different types of pain, like the visceral and somatic types of pain. And that is, that is something that they did. They compiled like some hundreds of papers and different studies at multi-institutions and all over the country. And they said that they couldn't prove that it helped with those other types, but they could prove that it helped with neuropathic pain. So I also wanted to mention that it also is not, it's not like super cut and dry, because also if you look at the chronic pain of those suffering from HIV or AIDS, the people that are taking antiretroviral medications, those medications cause a lot of side effects and symptoms. And so some amount of pain as well. Also, those things like weight loss and nausea. I'm not going to talk too much about them because this talk is about pain, but there are a lot of symptoms that can be helped. And especially with those suffering from this disease, also cancer, weight loss is a big problem. And so it's a really useful tool in the toolbox for these things. And so I wanted to just mention that there was one specific study that showed, or not just study, it was a combination of a bunch of papers and a bunch of studies. Up to a third of people that were that were suffering from like pain related to HIV or AIDS reported using cannabis for treating their symptoms, and there was 97% people had an improved appetite, and then 94% of people said that they saw improved muscle pain. And this is muscle pain, that that isn't the most medical term for pain necessarily, but that was the way that they had, like these participants sort of answer the question. And I think the bottom line is that there is sort of there's a huge improvement that can be seen, and not just pain but other things as well. And I think one thing I also wanted to mention is that there are options for, like, CBD is a nice option if somebody finds that this supplement, marijuana specifically, can help with their pain, that there is CBD that is an option. And then there's also a medication called Marinol, which is a derivative of CBD and marijuana that also does not cause it causes some like tiredness and sedation on a certain amount, not as much as like opioids or something, but it doesn't cause like the high or the like the mental changes that you see from actually taking like the THC that's in marijuana. So there are options for people that want to avoid those, but for the specific use of marijuana, it was studied by the CDC and National Institute of Health, and there's an encouraging information about it. Also, there's studies that say that CBD and like Marinol can really help with anxiety, and it can help with insomnia. And there are some studies that suggest it helps with chronic inflammation related to like arthritic pain, but there's just not enough out there for me to comment on it too much. But if people say it works, then I'm definitely not gonna argue. When people find something that works, then that's great. But just for purposes of this talk, then I just left that stuff out. So the next point was that I wanted to just take like a 10-minute break and let people go get a drink, go to the bathroom. And maybe before we do that, Anne or whoever's manning the chat, maybe we could just check to see if there's anything else that I can answer, or we can read.
I think we can probably touch on them and in your further training.
Okay, that sounds good.
Thank you so much, everybody. Yeah.
What'd you say? Sorry.
So let's see. So we'll be back at 11:26. Will that work?
Sounds good. 11:26.
Alrighty.
Sorry. Awesome. Thank you for whoever hit the recording button. So welcome back. This again is Thoughts and Solutions on Chronic Pain. I'm Becca Smiley through the Clinical Collaborative. Thank you for still being with us. So we have a little bit more to cover. We have 30 minutes left and I want to leave time for more questions too. So I'll briefly go over the next few sort of topics, but let's move on. So things I wanted to talk about too, before we move on to opioids as an entire topic on its own, is cultural considerations and racial inequalities related to pain. So I think the bottom line is, again, I'm talking a lot about through the perspective of a provider, but when a provider is approaching pain management for a patient, the first rule to avoid cultural stereotyping is to be open, authentic, sensitive, caring, and educate yourself. These are things that, you know, I can't stress enough, because there's a lot of research out there that says really how unequal things are. In 2016, there was a study this is a study that gets talked about in medicine all the time, because I think partly because it's just so disturbing. But in 2016, there was a study of 200 medical students at multiple institutions throughout the United States. And the study asked medical students a series of questions, and 22% of those respondents believed that Black people have less nerve endings compared to white people, and 63% thought that Black people have thicker skin than white people. And these are things that were really shocking to those that put out the questions and the survey, and the medical community at large was really disturbed by these results. So it really just says a lot about like the education that is being provided, and then, you know, what kind of providers are then being sort of like put out there into the medical community and are providing care for people. So I think I wanted to start off with that, and then also just talk quickly about a study that was published. Let's see, sorry. Oh, a study published last year also showed, not last year, this was in 2019, that showed for children that go to the emergency room with appendicitis, that Black children versus white children were less likely to receive pain medications for it. And that white Anglo-Americans, sorry, compared to other ethnic groups in the United States, are more likely to receive recognition for their pain and treatment with analgesics and like pain medication. So I think these are things that I wanted to focus on, and like really the bottom line is like self-reported pain is the most reliable indicator. Like I said at the very beginning of this, there's no thermometer for pain. There's no way to really measure it. You have to go with what the person is reporting. And providers need to know about studies like these to really be able to be introspective, introspective, and consider their own cultural biases, and even their own, you know, understanding their own culture and how that is brought into the picture. Because this was me just bringing up, you know, difference, focused on this one difference in these two groups, but, you know, obviously this could be a whole entire talk on its own about cultural considerations and sort of biases that go into pain management. So again, providers, caretakers, everybody needs to take steps to educate themselves on the different cultural needs of different groups too, because there's different cultural, you know, I don't have studies for these things that I can point to. I wanted to keep it really, you know, like study specific to really make sure that like the evidence is there to support some of these things I'm saying. But I know there are studies, I just don't have them cited here, so I won't talk too much about them, but about the different ways that people express pain, depending on, you know, your culture and where you're from. Pain, the way that it's shown is different depending on who you are. So knowing those is something that really needs to be like heavily educated in the medical community. I think there's some level of that that's changing, but I would say probably a lot of people would agree with me that probably not fast enough. Okay, so moving on to opioid use too, I think the biggest thing here is that, you know, avoiding opioids if you can for chronic pain is something that should be done, because there's all of these other options like non-medical, you know, ways to treat pain, and then adding on the things that are less risky for people. But if you're going to start opioid therapy, then all of the other options should be exhausted first, and that a provider should really set realistic goals for like where the client wants their pain to be. Because I think one thing that happens a lot is clients or patients that are coming in for their pain want to be pain-free, and it's important that providers really educate people on the fact that they're not necessarily going to make all their pain go away. So setting those goals is important. And then clinicians should continue opioid therapy if there's a meaningful improvement in pain, and that if the function and risks outweigh, or the benefits outweigh the risks. So that little phrase was taken right from like the CDC website, and I wanted to focus on that phrase because somebody brought up the point that there are clients out there that have been on opioids for a long time, and their providers are stopping them. So there is evidence to say that if it is, you know, if you shouldn't stop them necessarily if the risks or the benefits outweigh the risks, and you know somebody's, you know, quality of life is affected. So I guess I should have pointed maybe to that slide back then when I was answering that question, but it kind of goes with the same thread there. And then also the CDC recommends these clinical reminders for people that are prescribing opioids, which is using the immediate release opioids. So you start low and go slow. Start with the smallest amount of opioids you can, increase it very, very slowly to see where somebody can get their benefit without, you know, using too much. And then also the immediate release opioids is something, you know, that I comment on a lot, because if somebody's using a long-acting opioid, that means that like their pain is something that is, you know, has been really difficult to manage, and it's possible they might even have like a pain specialist or something at that point, because mostly like a primary care provider is just doing like a immediate release acting type of medication. And then like I just wanted to comment on some of like the things that going on in the background, which is like there's a law in California that says, you know, if you're prescribing opioids for somebody, that you have to prescribe Narcan, or the opioid reversing agent that is like commonly sprayed in through the nose. And to even have the ability to write a prescription for an opioid, you have to have a special license through the DEA and the Drug Enforcement Agency. And nationally, like they're tracking this, they're tracking providers that are giving out these medications, and you have to have a special license just to do it. And then there's also rules in all states that if you're giving opioids to a patient, that providers have to check this opioid database system to make sure that there's not other providers also giving opioids to these patients. So there's lots and lots of rules and regulations around opioids, and there's reasons for it. And, you know, I don't think I have to necessarily explain all of that, but it's a cumbersome thing for somebody to be prescribed opioids in this day and age because of all of the rules and regulations. So next, just like when I'm talking about reasons for all of like the restrictions for opioids, there's the obvious, the opioid epidemic and the addictive nature of these medications. But then, there's side effects that, are immediate. There's side effects that are a result of long-term opioid use. And then I wanted to talk a little bit about the difference between tolerance, dependence, and addiction. Because just because somebody is tolerant of opioids and using more and more of them, or even dependent on opioids for their pain, it doesn't necessarily mean they're addicted, and we'll talk about the difference. So I wanted to just say that the first thing is like the more immediate side effects, which is constipation and nausea. There's also respiratory depression and somnolence, or like fatigue, or like feeling very tired, basically. So because the opioids are like a central nervous system depressant, they slow everything down, including your bowels, so you get constipated. That's something that can be managed with medications like Senna, Colace, Miralax. These are all things people end up, there's more. You can do a stepwise approach, but basically anybody that's on chronic opioids should be on a medication for constipation as well. Nausea is something that occurs when you're taking opioids, and this is also managed sometimes. Like, it's usually people that are opioid naive that end up getting more of these immediate side effects of nausea. And then respiratory depression, again, this is like the slowing of the respiratory rate. And that's over sedation and drowsiness. When people get a bunch of opioids like in the hospital for any reason, then this is always Narcan is available, and always, people are watching for any sort of like over sedation, drowsiness that would lead to this respiratory depression, and like not breathing frequently enough to oxygenate your body effectively. And then for longer term use, there are things that, that are sort of like, yes, the constipation never goes away. People generally do like a little bit better with like the nausea. That can improve after using it for a long time. But the respiratory depression, the constipation, those never go away, the risks of those things. But the respiratory depression also, the risk gets lower as you build up tolerance to these medications. But interestingly, as you take more and more, even though you're becoming tolerant in all these other ways, constipation is the one of all of these side effects that does not, you don't become tolerant of. And in fact, if you're taking more and more opioids, you really should be taking more and more medications for constipation, because that's not something your body is going to kind of like become accustomed to. So, and then there's also just like, you can have, if you're on opioids for many, many years, you can have issues with sexual dysfunction, like impotence. You can have issues with immune system changes, like a weakening immune system if you're on it for years. And then one thing I wanted to mention was opioid-induced hyperalgesia, which is an oversensitization of pain because of long-term opioid exposure. So this is something that occurs not super uncommonly with people that have been on opioids for many, many years. Their pain threshold is different, and how sensitive they are to pain is different than somebody that has not been on opioids for a long time. So clinicians really have to be really careful about this. Like, if somebody's on opioids for a long time, then they have to have surgery. It's important that clinicians understand that this is a phenomenon that occurs. And in fact, what happens is people have to be on even more and more opioids for a shorter period of time. but this is important to know, because it's not uncommon at all. And then the difference between tolerance, dependence, and addiction. So tolerance is where you have to take a higher and higher dose of the drug to achieve the same effect compared to like when you first started it. Dependence is when a person stops using the drug and their body would like go through withdrawal. And that would mean, you know, even if somebody gets a headache when they don't drink a cup of coffee in the morning, that's also a level of dependence on caffeine. So it's not necessarily that they're addicted to it, but it's just that like your body, you know, is used to it for these certain things. And the addiction is actually where, you know, you have the tolerance and you have the dependence, but it's when the person keeps using and can't stop despite negative consequences. And you know, this is also like called substance use disorder, is what we call it in medicine. Okay, the last thing, this is the last slide, and then hopefully I'll have left enough time for questions and just conversation and stuff with the group. But you know, the bottom line is for all of this is that there is, you know, it's up to a provider to make sure that they're looking at a person as the whole person. When it comes to pain, they're considering who the person is, their goals for their pain. They're considering their culture. They're considering the clinician's own internal biases. The clinician is also considering all of the different options for pain management, and that includes all of these other therapies. That's not just medicine. And so I think the other thing is like also helping clients and patients to develop a strategy for their pain. So you're coming up with the clinician comes up, or the provider comes up with the plan. You know, okay, we're going to go to physical therapy, you're going to try acupuncture, we're also going to do, you know, these different medications, and see how your pain is. And I think the important part of it is incorporating the client or the patient into really remaining active and really improving their lifestyle, because that's what this is all about, right? So, you know, you have to help people engage in activities that might be more difficult due to their chronic pain. So it involves taking regular breaks and not just pushing through any task, and scheduling that rest, or the active time and the rest time. You know, asking clients how long they can go without having a pain flare up, and then scheduling that rest time in between. And this is the activity cycle that's been sort of researched and proven to be helpful for clients and patients to really remain active. With the appropriate plan, people can really remain active, and you know, with the right encouragement too. So scheduling the active time, scheduling the rest time, and making sure you're not pushing through a task to the point where then you're too exhausted the rest of the day to do much else. And you know, this can be used for things like mowing the lawn. Like maybe you go out and mow part of the lawn, you're not mowing the whole lawn. And you know, you just do a part of it and then you do the next part the next day or later that day or something. So then the next thing I wanted to mention is just like getting the most out of your visit with your provider. And this is, I think, important because I think a lot of people that are experiencing chronic pain also feel like there's not a lot of agency and, you know, control in their own, you know, care. So it's important to, this list is available for people to really consider, like how to make sure that they feel like they're participating in their care. So being prepared for the visit, writing down all the questions that you have beforehand, and then also going to the visit and providing very complete and succinct information, because the visits are, you know, sometimes only like 15 minutes long, and you have to really be able to like explain what you're experiencing like in a succinct way. And then also clients and patients should be encouraged to take medications as prescribed, because it's harder to, come up with a good plan as a provider if people aren't taking the medications the way that they're supposed to. And then also clients and patients should be encouraged to like listen carefully and write down notes, write things down, and then asking questions about what to expect. I think this is a big one. People will often be given a plan for their management, and maybe part of it is like an x-ray. Okay, so then if they don't set up expectations for like when the x-ray will happen or when the results will be read to them, then they're left feeling like they don't have agency and they don't have control over their care if they don't know when the result is coming, and then they end up waiting a week when they thought it was going to be one day or something like that. So it's really about like asking for information and like time frames, and things like that. So I think it's the point of this slide is really to understand like where the like patient agency and participation really comes into play. Thank you, everybody.
So much, Rebecca. This is such a helpful webinar today. I learned a lot myself, and we hope that everyone in our community learned a lot as well too. And we hope to see more of you and all of you at future events.
Awesome.